Achalasia, from the Division of Thoracic Surgery and Gastroenterology at Mayo Clinic.
Hi, my name is Shanda Blackman, and I'm a thoracic surgeon at Mayo Clinic, and I'd like to spend some time talking to you on behalf of the Department of Gastroenterology and the Department of Thoracic Surgery about diseases of the esophagus. We'll be talking today about achalasia, and this is a video that was uniquely tailored to you, the patient, to educate you about achalasia. We'd like for you to know the different ways that we evaluate patients who may have achalasia, the different treatment options that we consider, how we perform those treatments, and how you recover after those treatments. This video is intended to educate you, the patient, and empower you so that you understand how to take control of your disease, what your best options for managing your disease are, and how to expect your outcomes after you're finished with your treatment. We hope you enjoy the video. Thank you.
The objectives of this video will be to review the diagnosis of achalasia, to share common ways to evaluate a patient with achalasia, and to review different treatment options for patients with achalasia. Achalasia is a problem or a disorder of the esophagus. The esophagus is a long tube that carries food and fluid from your mouth to your stomach. When you swallow, muscles contract and sweep food and fluid all the way down the esophagus. At the lower end of the esophagus, where it meets the stomach, the esophagus muscle tightens. That is called the lower esophageal sphincter. Usually, this sphincter opens when food or fluid comes down the esophagus and tries to enter the stomach. When it opens, the food and fluid passes into the stomach easily. Usually, the esophagus is empty between swallows. People with achalasia have a hard time swallowing. The nerves that control the esophagus don't work well. When you swallow, the waves of muscle contractions don't happen. Because the sphincter doesn't happen or open correctly, food and fluid cannot pass into the stomach. Food is trapped into the esophagus. Over time, the esophagus may become wider than normal or dilated to hold more food and fluid.
Patients who have achalasia may suffer from a variety of symptoms. Some patients may complain that they vomit undigested food several days after eating a meal. Other patients may just have to eat slowly. Some patients may complain of heartburn, but it's actually not heartburn because the acid cannot make it back up to the esophagus. In fact, what they're sensing is food that may ferment in the base of the esophagus because it doesn't pass through the sphincter and then it regurgitates back up. Some patients may aspirate. Aspiration is where you try to swallow food and instead of going down your esophagus, it goes into your airway. Other patients may try to swallow and have a piece of food that becomes impacted or lodged in the base of their esophagus. There are basically different sphincters in the esophagus that help you to digest your food normally. The upper esophageal sphincter opens when you swallow, allowing food to pass into your chest part of the esophagus. The food passes through that part of the esophagus and then goes through the lower esophageal sphincter into your stomach. In achalasia, the lower esophageal sphincter is too tight. So most of the symptoms that people complain of are because that food cannot pass from the esophageal body down into the body of the stomach. Those symptoms are frequently present for many, many years. Some patients are unable to take in adequate food and lose weight. Other patients resort to taking a liquid diet, and over time, taking high-calorie liquids could result in weight gain. Therefore, a patient who suffers from achalasia is not necessarily a very thin, malnourished patient. There are a variety of ways to diagnose a patient with achalasia. Some of the tests that your team may elect to perform include a manometry test, where a probe is passed through the nose and used to measure the pressure in the esophagus, an ultrasound to make sure that there's not a mass in the esophagus compressing the area and giving you symptoms like achalasia, an upper GI contrast swallow test, an EGD or endoscopy, or any other test that may help us to distinguish whether or not you have chest pain from other organs or chest pain from your esophagus.
During your esophageal manometry or motility test, a small tube called a catheter is passed through your nose and into the esophagus. It measures the strength or pressure of the esophageal contractions at the upper and lower sphincters and along the length of the esophagus. This tube is in place for approximately 10 to 15 minutes or 10 to 15 swallows. You will be asked to take a sip of water, and after you've completed the test, the tube will be removed. During this exam, you drink a liquid which may contain barium or another contrast agent. Several x-rays are taken while you swallow. The contrast agent helps the open areas of your esophagus, stomach, and upper part of your small intestine look white on x-ray. The rest of the area looks more black on an x-ray. During this exam, a thin, flexible tube called an endoscope is passed through your mouth into your esophagus. It has a tiny camera at the end. This allows your healthcare team to see your upper gastrointestinal tract from the inside. This is typically performed with sedation and pain medication so that you are not aware that the test is being performed. After the test, you will be taken to a recovery room. During this exam, an endoscope is passed through your mouth into your esophagus. It has an ultrasound device on it. That device can identify whether there's something outside the esophagus that's compressing it. These compressions may look and act like achalasia.
Achalasia is treated in many different ways. Some patients are too frail to undergo any intervention other than medical therapy. The medical therapy frequently is not very helpful, but may be the only option available to very few patients. Some patients who are healthier can undergo a procedure or surgery. Those patients who have a procedure offered to them, specifically endoscopy, have the option of choosing either to have Botox injected into the esophagus. They could also have a dilation with a very large balloon, or they could have a novel procedure called POEM, per-oral endoscopic myotomy, where the endoscopist or surgeon team goes into the esophagus and cuts the sphincter through a natural orifice. Other options include surgery that can be performed either in an open manner or a minimally invasive manner. Typically, a laparoscopic modified Heller myotomy with a partial fundoplication is performed. We'll go through these different procedures in detail to help you to understand what each one entails.
Botulinum toxin, a muscle relaxant, is injected into the esophageal sphincter during an upper endoscopy. The toxin weakens the sphincter muscles, allowing food and fluid to pass into the stomach. This injection is helpful for many people, but it offers only temporary relief, usually lasting 3 to 6 months. These injections may cause scar tissue to build up. That can make it more difficult for other treatments to be used in the future if needed. There is no overnight hospital stay after a Botox injection, normally. Pneumatic balloon dilatation stretches the sphincter muscle just above the stomach. To do this, a catheter is inserted into the stomach. The balloon is passed through the catheter. When it reaches the sphincter, the balloon is expanded gently to reach a 3 centimeter dilation. When the sphincter reaches this size, its muscular fibers tear. When the muscle is torn, the sphincter can no longer close that lower esophageal sphincter. The balloon is then removed. There is no overnight stay in the hospital for this procedure. The benefits of balloon dilation may be permanent. However, some people need repeat treatment because the sphincter may become scarred and tighten again. In the first attempt at balloon dilation, if it is not successful, the procedure may be repeated. The chance of leakage from this area or perforation increases with successive dilations. POEM stands for per-oral endoscopic myotomy. Per-oral refers to going through the mouth. Endoscopic refers to the catheter that uses tiny tools or instruments to perform the procedure. In this first image, an endoscope is inserted into the esophagus. Through the endoscope, the lumen or the inside of the esophagus can easily be seen. A blue substance is injected into the layer of the wall of the esophagus called the submucosa. A small knife is then used to make an incision on the inside of the esophagus so that the scope can be passed inside the wall. After the incision is made, the scope is then passed into the small flap of tissue that is created when the incision is made on the inside of the esophagus. The scope uses tiny instruments to then begin to create a tunnel through the wall of the esophagus in the submucosal layer. The scope continues to use the tiny instruments to dissect through the layer of the wall of the esophagus until it enters the wall of the stomach. The small instruments that are passed through the scope carefully release any attachments between the two layers so that the scope can completely pass well into the stomach layer. After the scope has created the channel through which it will work, small instruments are passed through the lumen of the endoscope and are used to divide the inner circular muscle layer of the esophagus. Once the inner circular muscular layer is cut, the outer longitudinal muscular layer can also be cut. This muscle is cut all the way down to the level of the stomach. Once the procedure is complete, small clips are applied on the inside of the esophagus to close the incision that was made where the scope was entering into the wall of the esophagus. Laparoscopic modified Heller myotomy and partial fundoplication is a very established surgical procedure that is performed by inserting a camera into the abdomen, inflating the abdomen with CO2 gas, and looking inside the abdomen at the esophagus and the stomach and making an incision from the outside of the esophagus and stomach towards the inside, but not completely through the wall. The outer layer of the esophagus, the sphincter, and the stomach is divided up to the level of what is called the mucosa, which is the most inner lining of the stomach and the esophagus. Scissors or a cutting device are used to separate these layers and divide them all the way up to the mucosa. The muscle is cut well into the chest and all the way down onto the stomach, taking care to avoid a small nerve that passes in the same area called the vagus nerve, and taking care to extend the incision well onto the stomach such that the myotomy is complete. After the incision has been made, the sphincter no longer works. Therefore, most surgeons perform some type of a wrap of the stomach around the esophagus. This particular picture shows what is referred to as a toupee fundoplication. A toupee is a partial wrap. The stomach does not completely wrap around the esophagus, and it is brought around behind the esophagus and sewn into place. The next procedure that could be performed as a wrap is called a door fundoplication. The door fundoplication involves sutures that are sewn to the esophagus. The anterior portion of the myotomy is covered with separate layers of stomach that are sewn to each side of the myotomy. This illustration shows the first layer of coverage. The second layer of coverage is shown here, and the final layer of coverage is shown here. These multiple rows of sutures ensure that the front of the stomach is brought up and over to cover the entire area of the myotomy exposed within the abdomen. When deciding which treatment is correct for you with achalasia, you have many options. Many of the options may have already been discussed with your care team. Botox is particularly helpful for patients who are not fit to undergo surgery, or in patients who need a temporary opening of the lower esophageal sphincter. The disadvantage of Botox is that repeated injection may be required. It may also create some scar tissue, making further intervention somewhat more difficult. Botox is a short-term treatment for achalasia. Dilation, however, is a better long-term treatment than Botox. Dilation can last a lifetime or may only last a short time. When dilation has to be repeated, there is an increased risk of perforation or leakage of the esophagus. Dilation is another option. However, when dilation is used, it frequently creates so much scar tissue that performing any of the other procedures may be complicated. A per-oral endoscopic myotomy is another option available to patients who do not want to have surgery, who are worried about scar on their abdomen, or who want a less invasive procedure. The per-oral endoscopic myotomy has the disadvantage of not being able to offer a patient an anti-reflux procedure. It is not currently known whether or not this anti-reflux surgery is required for patients who undergo per-oral endoscopic myotomy. The other disadvantage of a POEM procedure is that it is relatively new technology and the long-term effects are not known. The final option for treatment for achalasia is surgery. Patients who choose to have surgery can expect an overnight hospital stay, discharge the following day, and a liquid diet after surgery for a few weeks. Patients who choose surgery have a very low risk of perforation, should have a complete myotomy, and should expect to have an anti-reflux procedure performed to prevent postoperative regurgitation and reflux of food from the stomach. Please meet with your care provider to determine which option is best for you. When taking care of yourself after treatment, it is important that you pay attention to special advice from your doctors. The day after your procedure, you may shower. You may walk, climb stairs, or do household activity. For 3 weeks after your procedure, do not lift anything over 10 pounds, which a gallon of milk weighs approximately 8 pounds. Do not take part in any activity where you could have abdominal trauma. For 4 to 6 weeks after your procedure, do not do sit-ups, weightlifting, or abdominal crunches. Do not drive a car, and also follow this direction while you're taking pain medicine. With regard to dietary guidance, for 2 weeks after your procedure, do not eat solid food. It may get stuck as it passes through the swollen lower esophageal sphincter. If this happens, the food may have to be removed at the hospital. Follow a liquid diet. You can eat anything you could pour through a funnel. The liquids do not have to be clear. You may drink Ensure, Carnation Instant Breakfast, soup, or any other liquid you would like to drink. Protein shakes, soups, and thickened liquids are okay to drink. Yogurt, pudding, and ice cream are also okay, as long as they melt in your mouth. When caring for your incisions, for 48 hours after the procedure, you may take off any bandages or dressings after they have been on for at least 48 hours. Medication. You may not need to take your heartburn or reflux medication after this procedure. If you have symptoms, you may continue taking these, but you should not need them. Get the liquid form of the pain medication that the doctor prescribes for you. If your provider prescribes a pain pill, that is okay as well. If you can't get the liquid form, cut the pain pill in small pieces. This will help the pill to pass through the lower esophageal sphincter near your stomach. Some prescriptions and over-the-counter pain medication can cause nausea and constipation. If your pain is not too bad, try to use Tylenol or Aleve or Advil instead of other medications that can make you nauseated. Avoid nausea and seek medical attention or medication to help you treat the nausea, as vomiting can harm your procedure. Common problems. If you have incisions, you may have swelling at those sites. It should go down within the next 2 weeks after your procedure. You may have trouble swallowing due to swelling in the esophagus. Be sure to follow the diet directions provided. If you continue to have trouble swallowing for many days, call your surgeon's office. Tell a member of your care team how smoothly or not smoothly the liquids are going down. Feel free to ask when you may try other foods. You may have constipation, which is not being able to have a bowel movement due to the pain medication. Drink plenty of water to help avoid this. If you begin to feel constipated, take a laxative or drink fruit juice. If a piece of food is stuck in your throat, drink some warm water slowly to see if it will pass on its own. If not, call your doctor or your gastroenterologist to explain to them that you are having problems. When to get medical help. Call your provider if you have a temperature greater than 101 degrees Fahrenheit, if you vomit or become unconscious, or if you have food that gets into your lungs, if you have severe abdominal pain, if you have continued nausea, especially with vomiting, if you have a pain in your stomach that does not go away, or if you have questions that are not emergencies, call the office during business hours.
After you recover, feel free to ask your team any questions that you have regarding what was done to you or what will be done in the future. We always like to encourage you to follow up with us after your surgery so that we know the effects of what we have done what we expected them to do. We'd like to thank you for this opportunity to educate you about your disease. We look forward to engaging with you and meeting with you in the clinic and talking with you and interacting with you on rounds in the hospital as we take care of you and help you to overcome this disease. We hope that you weigh the risk and benefits of each of the procedures that we offer and that you make a wise choice along with us making recommendations. We hope that you consider all of the advantages that Mayo Clinic offers you, specifically a highly interested, a highly trained, and specialized team that focuses on just your disease to give you the best care available. Thank you for this opportunity to educate you. We look forward to meeting you.